Hello, I'm Mead Munger. I've had many experiences working in challenging situations. While serving several years on the leadership team of a top consulting firm known for restructuring and transforming companies, along with solving big problems, I did things like have a lead role on the team that restructured a major U.S. auto company through a deal with the U.S. government that included mechanisms in place to help save thousands of auto suppliers during the recession. Assisted a major oil and gas company with a dramatic oil spill in the Gulf of Mexico, led the wind down of a multi-billion-dollar subprime lender as the chief restructuring officer during the subprime meltdown, worked on many of the largest U.S. bankruptcy cases and major transformations of companies. I thought that I'd seen a lot, and then I experienced what it is like to work in the U.S. healthcare industry. Let me share some headlines with you. The U.S. healthcare system is by far the most expensive in the world. Yet the quality of care in the U.S. ranks at the bottom of the world. Big contributors to these problems include significant administrative cost. There really is no healthcare system. There's a bifurcation between a market justice and social justice system. It's a multiple payer system with many different approaches. Let's go take a look at some of these charts. Starting with healthcare costs, the U.S. healthcare system costs each patient about $12,000 per year, roughly double all other developed countries throughout the world. The U.S. spends nearly 20% of GDP on healthcare, again about twice the average of all other developed countries. Now taking a look at quality, we can see from this chart the U.S. healthcare system performance scores are at the very bottom, far below all other developed countries. The life expectancy rate is the lowest by far. For the United States, it's in the mid to the high 70s, where other developed countries are well into the 80s. Taking a closer look at healthcare costs, U.S. healthcare expenditures are growing 10% per year. They've surpassed $4 trillion annually. $1 trillion of it is for administrative costs. And very quickly, this should give you a sense of the structure of the healthcare system in the U.S. This picture speaks for itself. To simplify it, the U.S. has a bifurcated approach. Half the industry is treating healthcare as an economic good in a market justice system. The other half of the industry treats healthcare as a social good in a social justice system. The country has effectively compromised, whereby about half our health insurance is through our employers, and a majority of the other half is through the government, largely in the form of Medicaid for low income and Medicare for the elderly. And for half of the insurance paid privately is facilitated through over 900 commercial insurance providers. Shifting gears a bit, what about value-based care? The intent of value-based care is to address all these issues and challenges. Everyone seems to be bought off on a concept called triple aim: improve population health, reduce per capita healthcare costs, provide better experiences for patients. The idea behind value-based care is to advance triple aim. Many initiatives have been undertaken to achieve value-based care. Let me tell you more about it. The goals are better care for individuals, better health for populations, and lower costs. And there's been a number of formal initiatives to achieve this. We have MIPA from 2008, the Affordable Care Act with provisions in 2010, the MACRA Act of 2015, and MIPS in 2019. It all sounds great, right? Well, let's talk more about it. How much progress has been made since 2008? Value-based payments are moving at a snail's pace, 15 years later. What we're really talking about here is changing how healthcare providers get paid, going from a fee-for-service model to a value-based care model. A fee-for-service model is basically where doctors get paid a certain amount for providing a certain procedure. For example, Medicare pays $92 for a 99213, a 20 to 30 minute office visit. However, every other payer may pay something different for a 99213. Basically, every patient that walks in the door has a different payer that pays a different amount for every procedure. A big portion of the $1 trillion of administrative cost is related to providers dealing with the process of collecting from all the different payers that pay all the different rates. We can talk about that some other time though. The point here is to move to value-based care. But what does that mean? Good question. Therein may lie the problem. Value-based care models come in many different forms. The general idea was to go from shared savings, bonuses for reducing costs, to quality of care rewards, to shared risk, downsides for providers that spend too much or don't have good quality, to capitation payments, fixed amount per patient with quality benchmarks, to bundled payments, several different providers coordinating and cooperating on care episodes. The situation is, however, that there are many different models, and of course every payer tends to take a different approach. Let's highlight some of the common ones. Value-based care has alternative payment models, population-based payments, accountable care organizations, patient-centered medical homes, managed care organizations, and a variety of other value-based models. This comes with many different concepts: shared savings, episode bundles, capitation payments, global budgets, to networks of providers coordinating care and teaming across multiple organizations and systems, to even insurance companies and healthcare companies merging together and running both insurance and healthcare delivery. This requires many different back office challenges. This brings big considerations to all the changes that healthcare providers have to make to their back office to accommodate these models. It requires healthcare providers to effectively navigate the challenges posed by a payment model that requires sharing and analyzing of data in ways that fee-for-service and its legacy revenue cycle management systems and business processes never contemplated. The bigger issue is that, speaking as an accountant and technologist with expertise in transforming back offices, what are you transitioning the back office to? It is highly unreasonable to think that a provider can accommodate all these different models. So how has it been happening? Providers are consolidating. There has been a meaningful decline in sole practitioners. Many others are just sticking with a fee-for-service model, as we saw earlier that there is still less than 7% value-based care. So where is the yellow brick road to value-based care? It seems to me that we all need to agree on what is Emerald City. What is the land of Oz when we get there? It's not a yellow brick road right now. It's a fork in the road, more like a spider web, given all the directions that providers can go. But maybe we can all start with some guiding principles: better measurements of cost, better measurements of patient quality, ability to collectively track population health. However, another big challenge is the infrastructure that providers need for all this. Let's talk about that. A major challenge is having to transform the back office. Think about that. Healthcare provider functional processes and systems have been built for complex fee-for-service models, for which they still have many challenges. We could have a whole discussion about that. But focusing on value-based care, there are whole new sets of information that need to be captured, calculated, and transmitted, coming from numerous data sources. Without getting into all the detailed complexities, let's cover the major concepts. Starting with, understand cost of care per patient and per type of patient to know what per patient pay rates are necessary to make money. Decision support systems to efficiently manage patient care and maximize quality through systematic workflows and assignment of care personnel, especially in care coordination models. Robust and reliable interoperability data to share patient data between provider systems while complying with HIPAA standards. Benchmarks and key performance indicators for patient health quality, including calculations that measure quality performance payments. Patient experience measurements and tracking. Population health data sharing with social determinants information necessary for understanding performance results and benchmarks. Revised accounting processes such as gap-based revenue recognition requirements that accommodate new payment models, as well as how to record liabilities exposure of capitation payments that may be insufficient. This is obviously a lot for healthcare providers to take on, and my guess is they don't want to invest their time there. They want to work with patients. It seems to me that until we all get on the same page with specifically what the land of Oz needs to look like for value-based care, and there is consistency among the payers, it's difficult to find the yellow brick road to value-based care. While there's still a lot of work to do to get consistency across value-based care, there are key steps that we can all take now to make progress down the yellow brick road.